turning in, I believe, in October. We are recording. Um, and we ask that you utilize the chat function to drop in any questions, or you can hold them for the end. We do have a Q&A section as well. Um, all right, let's go to the next slide. Yeah, as you know, we're recording. HCA doesn't permit AI note-taking. And overall, this webinar, we're going to be using the capacity building application that has had some recent updates to it to sort of guide us through. We won't be going over every single attestation, but we will be focusing on the areas that um, are important and sort of take some additional thought or preparation in terms of timeline. Like some items just take several months to complete to sort of prep you for that. And I'm going to go ahead and pass it off to Monica, which all of you should know, I believe, who's going to uh, get us started. Thank you.
Yeah, thanks, Michaela. Good morning. We're still in morning, everyone. Thank you so much for joining. My name is Monica Bird. I serve as the Justice Involved Member Reentry Supervisor. What that means is I do a lot of things that are 1115 waiver connected. And today we are going to start with kind of going over the objectives of this webinar. And so we have the milestone overview, which is what Michaela just kind of talked about, as well as the capacity building application requirements. And then we will have time at the end for some questions. And so, yeah, we can go to the next slide. And the next slide. So as many of you know, that the Reentry Initiative is really set forth to make sure that the folks that are transitioning out of carceral settings go back into their communities better and healthier. And so with that, you all have decided to participate with the Reentry Initiative. And so as of May 1st of this year, the intent to participate was submitted by each of you. And then the next section or the next step that we will be going through is the October 1, which is the deadline for the CBAs or capacity building applications will need to be submitted. And then from there, we look like we have the Milestone 3 readiness assessment. And then, of course, the go live date for Cohort 3 facilities is going to be July 1 of 2026. After that, we do want to do a progress report, just make sure that everything is aligned with the information that was submitted and make sure that we are following the guidelines that have been set forth by CMS as well. And then the final progress report, which will be done later, which is around October 1st of 2027. And we can go to the next slide. So for milestones 2 and 3, there are attestation questions that the facility will need to attest to. This requires facilities to complete also an optional IT infrastructure budget in milestone 3. So I do want to make sure that I make this kind of separation. The capacity building or the budget that is required in the milestone 2 is pretty much for the capacity building and implementation funds. And then the IT infrastructure budget, we do understand that some facilities may not know everything that they need. That does become a requirement in milestone 3, but it is optional for you to submit that in milestone 2. And so once we get to milestone 3, that is the readiness assessments where facilities will really have to show us their plan, right? One of the things that I've been really encouraging facilities to share is we understand that we have hopes and dreams and ambitions of how we want things to look, but I think the biggest point of this is to really make sure that there is a plan for you all to implement these services and how you're going to achieve each of these requirements that have been laid out in the CBA. And so that's important for you all to also be able to pass that readiness assessment, which goes through an initial review by the transformation implementation team. Our SMEs are involved from different departments, and then it goes to our executive leadership as well. And so communication is a huge part of this process to avoid any delays. And we are always here to provide any technical assistance as well. Next slide, please. So the capacity building application is broken into different sections. One is no cost to individuals. And then we have the staffing and governance and the resource structure. And I'll kind of give a brief overview of each of these. We also have the Apple Health eligibility application support, the provider enrollment and billing, which is a big one, reentry targeted case management, the support for medications, services for CAA, eligible clients, excuse me. And then there are a set of optional services that the facility can offer as part of that as well. And we can go to the next slide. So for no cost to individuals, we do ask that the participating facilities are able to attest that the services that they are providing are not being charged to those individuals who are eligible for Apple Health. Support in applying for Apple Health coverage. This includes like assisting those individuals with submitting applications and then receiving medical care along with any prescription drugs and case management, labs, radiology, medical equipment, and supplies. And then also a communication in any form. So this could be emails, phone calls, it could be mail, snail mail, and copies of their medical record as well. Healthcare providers include community-based physical health, behavior health, and health-related social needs providers such as community health workers, recovery coaches, accountable communities of health, and managed care organizations, which are our MCOs. And so we can go to the next slide. So under the staffing and governance and resource structure, the carceral facility must establish a staffing, governance, and resource structure to support the planning and decision-making for the reentry initiative. This is going to be a huge, huge component because once you do get to milestone 3, we will ask for you to show an organizational chart of how these services and are being given and what that looks like, who reports to who, and who is held accountable for providing these services. This is to help establish staffing structure, support the program requirements. The carceral facility has defined the governance structure for decision making. So we want to know who those key partners are, even like whether they're internal or external partners. And then in the milestone 3, we also want to ensure that there is appropriate space and technology for providing those appointments. So milestone 3, you're getting closer and closer to that go live date. And so we really want to make sure that there is either in-person or telehealth ability in the facility or out of the facility, as well as interpreter services for those who are unable to communicate or English is not their first language that are by non-custody staff. So, and we can go to the next slide. So with Apple Health eligibility and application support, the carceral facility must be able to verify Apple Health eligibility for clients and assist those individuals without coverage to apply for Apple Health by submitting an application. For short incarcerations, whether you're a jail or juvenile detention facility, the carceral facility must verify Apple Health coverage for individuals within 24 hours of the intake. And this is not necessarily required if the individual is incarcerated for fewer than 24 hours. For short incarcerations, the carceral facility must submit an application for Apple Health within 2 business days of an individual's intake. And that could happen by navigators. And then those navigators could be a part of your staff that is in the facility if they complete an eligibility training and become assisters to submit the Apple Health applications as well. And so I just want to pause to make sure there aren't any questions in the chat that I may need to answer. And I know we'll have a section at the end too, but just wanting to make sure. And I'll depend on our team if there's anything that came up. All right. Thank you so much.
I had a question. When it says the 24-hour intake, is that still a business day or is that within the weekend as well?
Can you reframe your question? Are you referring to the eligibility check within 24
Yeah,
hours of
so
their intake?
for short incarceration, it gives you a 24-hour window, but if the kid comes in on like Friday night and they serve Saturday, Sunday, and then they're out Monday before, is that a business day or is that 24 hours period for Apple Health?
I Yeah, thanks for that question, Michael. Author, I see that you came on. I'm gonna go ahead and let you answer that.
Yeah, I think it's passing off to me next too. So the answer to that would be 24 hours, right? So there are some of the benefits, and we'll talk about this a little bit as we go forward into more of the benefits discussion that, you have so many business days to start that, like the reentry targeted case management, for instance. But there are some of them like the SUD benefits that, you have to start treating them within 24 hours of them being in the jail, right? So this waiver covers those who are Medicaid eligible. So it's really to your advantage to be checking their eligibility as quickly as possible. That way, if you have an SUD issue, you're not going to be able to treat and bill for those services if you don't know they're eligible, right? So that would be what I would say to that, Michael. So it's really beneficial and really important that you check their Medicaid eligibility because you need to know that so that you can bill for services. Does that help?
Yes, thank you.
Yeah, yeah. And I think I'm from here, right, Monica?
Yeah, you are. Take it away. Thanks.
All right. Next slide. So my name is Arthur Andrews. A lot of you may have seen me talk in other. Oh, well, there's one more slide here. So Tamara.
Sure, let me take on this one. Hi, my name is Tamara. Sorry about about this. And I am eligibility policy manager with the eligibility team, and just talking about incarceration and release date notification. So for carceral facilities, the expectation is that the booking and release information will be put into their systems within 24 hours of intake or release, and that applies to both jails into their jail management system, and for DOC would be Omni. And for the JD facilities, we work individual with every JD facilities on their booking and release notifications. And Arthur, take on. Thank you.
Perfect. Okay, so my name is Arthur Andrews. I'm an occupational nurse consultant here at the Healthcare Authority. Many of you may have seen me talk in recordings and in webinars before about some of these services. I'm just going to talk about all these sections in the CBA as it pertains to benefits in a high overview. I'm going to try to touch on some of the common things that we're seeing, or some of the things that maybe you need to pay attention to that we're seeing in when these readiness assessments and CBAs are being reviewed. And so we're going to go over a little bit of each of these, and then I'll be passing it off to Monica for another section at the end here. So let's go over the first one here. Next slide. So Apple Health provider enrollment here. So anybody who is providing Medicaid services needs to be enrolled and known to Medicaid. And that includes, that approval of the core provider agreement in Apple Health, which is part of the enrollment process. Um, I will tell you that we have run into some where the correctional providers that are providing services to some of the facilities are not known to Medicaid. And in some cases, they don't even have what we call a national provider identification or an NPI number, right? So it's really important that you're having those discussions with those providers who are going to be providing services to your jail, and to make sure that they have an NPI number, that they're enrolled and known to Medicaid, and that they can provide services to all 5 MCOs, which we're going to talk a little bit about as well. So all that can take some time, right? So if they're not known to Medicaid, this to get enrolled in Medicaid can take up to 2 months, depending on the complexities that are there, and what is known and what is going on there. So we are hearing that, if your county has an NPI, it can be difficult, and there are some extra steps to jump through for your facility to get an NPI if you need one, right? Not every facility is going to need to have an NPI, but just knowing that, these things, each individual thing can take some time here, right? So on for each mandatory service, the correctional facility, it's really your responsibility to identify providers who can serve all Apple Health clients, regardless of which of the 5 managed care organizations they're enrolled in, right? Um, so there, just to break that down, there are 5 organizations that the state contracts out to provide Medicaid services in the state of Washington. And, it's not, clients that are in your jail could be served by any one of those 5 MCOs. Plus, there's a population known as fee for service that's not covered by MCO that you would bill directly to the HCA for. In addition to, needing to make sure that, you can provide services to all 5 of those MCOs, there's also contracting and credentialing that has to occur with all 5 of those MCOs. And that can be a time-consuming process too. There is a separate process for each MCO. That's just, that's the nature of how things work in healthcare, and what is happening here. So, the providers that are providing services, they need to have an NPI. They need to be enrolled in Medicaid. They need to be contracted and credentialed with all 5 of the MCOs, right? If you have a provider that says, we're not going to contract with a specific MCO, then it's really on the correctional facility to be able to identify a provider who can serve those particular clients, right? So just recognizing that, your NPI can take some time, getting enrolled in provider 1 can take up to 2 months, and then that contracting and credentialing process can take up to 3 months with each of the MCOs. So this can be a time-consuming process to get through. Community-based providers, I think I've touched on this a little bit. They also need to be contracted and credentialed with the MCOs. This is just like, any doctor we would see, any provider we would go see on the outside. It's a question of, do they take that particular insurance carrier? And, there are cases where they take all 5 Medicaid MCOs on the outside, but sometimes community-based providers, they don't contract with a provider for whatever reason. And it's important to be able to identify that and know that, so that you can make plans to be able to provide services to those individuals. There is a waiver here for the credentialing process only, not the contracting. If the correctional facility hires medical staff and has medical staff in their facility, and they're going to be billing on behalf of those providers, right? So you're going to be acting like a clinic. So the correctional facility would need to be enrolled, need to have an NPI, enrolled with P1, and then they would be listing those providers in their facility as servicing providers under their NPI. There is a 1-year grace period for the credentialing piece only, because that can be time consuming, and so just recognizing that there's a complexity there, that if the correctional facility is going to be doing the billing, then there's likely a credentialing waiver there for 1 year. If the correctional facility is not going to be billing, they're going to be defaulting to the community provider to do that billing, then that waiver period does not apply, and normal contracting and credentialing rules would apply. Next slide. The billing piece. So the pharmacy is a little different, right? So The pharmacy used by the correctional facility, pharmacy has to be billed in real time through the point of sale system. That's true across the healthcare spectrum in Medicaid in the state of Washington. So that means that medications that are dispensed, right, to an individual, and we're going to be talking about that, like that 30 days at release. Those medications need to be individually labeled with client-specific labels, and it needs to be billed for in real time at the point of sale. There's only a couple of facilities in the state that have internal pharmacies that are registered as pharmacies. So what we're seeing is most correctional facilities, they're using a combination of maybe mail order and partnering with community pharmacies to make this happen. Do want to point out that you'll see in the next bullet point there that for those just like the providers, pharmacies need to be known to Medicaid. They need to be contracted with the MCOs. So it's important to also check with your local pharmacy if you're going to partner with a community pharmacy. Are they contracted and credentialed with all of the MCOs? There are instances where they do not for a variety of reasons. And for instance, if they don't contract with a specific MCO, then the correctional facility would need to identify how do I fill these medications for that population, for that MCO. So we are seeing a lot of correctional facilities that are partnering with more than one community pharmacy just to make sure that they have enough coverage in case something happens. So, but you know, if your local community pharmacy takes all 5 MCOs and is contracted, you could be just fine with the one. There is, for those facility-based providers, the correctional facility can bill provider 1 and MCOs for reentry services directly, or they can work with a third-party administrator, claims clearinghouse. The HCA is bringing on a TPA to help with billing if you want to bill correctly to serve as a clearinghouse. Correct me if I'm wrong, somebody, but it's going to be November 1st is when they're coming online. And we're going through that process right now. So just know that is there. And if you want the TPA's assistance in direct billing, the facility is going to be doing that direct billing, then you should really check that box in the CBA saying that you would like that technical assistance and that you would like to use the TPA. So also calling out on the pharmacy there, I don't want to miss this, that the Reentry Initiative does not reimburse correctional facilities for stocked medications, just kind of reinforcing that medications have to be billed in real time to the individual. The exception to that would be those medications that must be administered by a medical professional, which are billed on a medical claim, right? So, all right, next slide. All right, so we'll get into the benefits part of this here. I'm going to give a high overview of reentry targeted case management here. There is a webinar up on our website that just focuses on reentry targeted case management. So there's a lot more information in that webinar, but I'm going to go over the high points that we're seeing and kind of touch on some of the things that are really important to know going into this. So reentry targeted case management, this is a medical-centric case management. Many facilities are doing care coordination now, and you're doing a lot of these connections. But there are a couple of components that are new to this that are required. When CMS approved the waiver, these are the 4 components that are required in case management services here. And this is pretty typical of medical-centric case management or social worker-centric case management. Those 4 components are that reentry health assessment. This is a comprehensive health assessment. This is also a person-centered care plan, reentry coordination, and that warm handoff. So the top 2, I want to talk about those a little bit. The reentry, the comprehensive health assessment is probably new to a vast majority of correctional facilities here. A lot of you are doing very extensive intake assessments at booking, and that intake assessment can be used to fuel and feed this reentry, this comprehensive health assessment that the medical professional would do. But it really is an all-encompassing, holistic approach. It should identify unmet needs for SUD, mental health, physical health, behavioral health, those health-related social needs. It's really all-encompassing. I am an RN, so I tend to think about these things from a very medical standpoint. RNs can do this, this reentry comprehensive health assessment. It's more of a social worker centric, where it's kind of it's an inventory of the individual's needs and working with all those different of those different entities that may be working with the medical staff, working with the correctional staff, those types of things, and working with the individual. The care plan, it should be person-centered, right? Care plans are pretty standard for RNs and social workers and other medical professionals. This is not new information for any of those of us who have been doing this, but they should be person-centered and not cookie cutter for the same care plan for each individual. It should be informed by the comprehensive health assessment, and it should be goal oriented with specific tasks in mind for what needs to happen for that individual. Those two things do require licensure in the state of Washington. Comprehensive health assessments does require a certain level of licensure, and so does the care planning. We are encouraging a team model here. The P&O guide lists out who can do these things. RNs, licensed social workers, and there's some other mental health professionals that can do this. Does this mean that an RN or a social worker would need to do all of the work? Absolutely not, right? As an RN, if I'm doing case management, I'm going to delegate and I'm going to pull in other team members as appropriate. A good example of this would be, somebody says, I don't have a PCP and I need to schedule a PCP in this appointment in this area. As an RN, I don't have to make that call. Somebody with who's unlicensed or somebody who doesn't have a license that rises to the level of being able to do the health assessment could certainly make those calls. Do want to call out here that a lot of facilities are using LPNs, and I love LPNs to death. They are nurses as well, but their licensure does not allow for the development of comprehensive health assessments or that development of the care plan. LPNs can certainly be used to inform and help build that, but it really needs to somebody who has a licensure at where this would fall in their scope, who needs to sign off on this health assessment and this care plan. Coordination, facilities are already doing this. You're already connecting them to outside resources and already doing these types of things. This is what you guys are already doing. So calling that out, and then that warm handoff, right? So this is a medical centric warm handoff process where if that case manager is changing between the pre and the post release period, that you're connecting with that post release RTCM, which is probably going to be the MCO. And making sure that you're handing off what's been done, what needs to be done, what's outstanding, and any other pertinent information. We've gotten a lot of questions on this in the past. Just want to call it, I used to be a correctional officer in a former life. We did this in corrections as well. We called it a pass down in corrections, where the next officer would come on and I would tell him the inner workings of the shift, right? What is happening? What has happened, what significant events have occurred, and what should they be keeping an eye out on, right? So same type of thing here, only it's medical centric. So I think I've covered everything on this slide, so we can go to the next slide. It's a lot of information, I know, but really the important things to take from there are that the reentry health assessment and the care plan do have licensure requirements there. So it's really the correctional facility needs to ensure that the client receives that health screening to identify those client needs. I've talked about this a little bit on that first bullet point. So really, every facility is doing some kind of intake booking, right? And you guys are already doing pretty extensive ones. In fact, most of the ones that I've seen are extremely extensive. You can certainly build upon what you already have. We're not asking you to build something new. If you look in the P&O guide, it does state, what should be included in your comprehensive health assessment. And as an RN, I would 100% take that intake screening that you're doing and use it to build upon what I need, right? And in some cases, it may fulfill the need. So it's just a question of, what does that person feel is missing? What needs to be done? Is there new information since the booking period, right? I worked in the ER for a long time, and I know that sometimes information can change even 24 hours later. So that health screening, that's what we're calling out here, really screening those clients for their want to participate in RTCM. And for those longer stays where you know they're going to be in there longer, this would not probably not happen in a local jail, right? But in the county jails, DOC, they're on the 90-day pre-release period that would happen on the back end of release, screening them for services before that 90 days as well. And keeping in mind that, if you screen an individual once and he says, no, I don't want to participate in this, they need to have the ability to opt in at a later date. And, I know that's pretty common, at booking, maybe they're not cooperative or they don't want to participate or they're just not in the right frame of mind to be, making those decisions. A couple days goes by and then they say, hold on a second, I do want to participate in that. And they need to have that option. So it's not a one-time declination and then that's it. We're not gonna offer it again. So if they want to opt in at a later date, they certainly can. And then, calling out here on the second bullet point that it's really up to the correctional facility to ensure that they have access to pre-release RTCM. We're seeing a variety of ways that correctional facilities are doing this. Some are hiring staff or using their medical staff to provide this because they have people that are qualified to do this and doing that. Some facilities are partnering with community organizations. The MCOs can also do this. They can do this pre-release RTCM for you. Telehealth is going to play a key role here. Just know that if you want the MCOs to do that pre-release reentry targeted case management, they need at least a 90-day on-ramp. And I encourage, as long as if you know well in advance that, start having those discussions with the MCOs early, because they need to make sure they need to understand volumes, how you're going to share data, how are they going to connect with those members in the timeframes that are required, and do all those good things. So at least 90 days. I encourage more than that if you already know how you're going to provide those services. And then that warm handoff. If the care manager is changing, we've talked about this, that needs to occur. But if it's not changing, say the MCOs are responsible for the post-release RTCM. If they're going to provide that pre-release, then that warm handoff doesn't need to occur because that reentry targeted case manager isn't changing. But if your facility is providing that and then passing off to the MCOs at the time of release, then you would need to make that connection and make sure that warm handoff occurs. Next slide. Talk about medication support here. So next slide. So the required benefit here is that your facilities are required to provide support for substance use disorder medications in that 90-day pre-release period. I do want to call out that you'll see in the CBA and the readiness assessment that it's just not about SUD medications, but also withdrawal. So the requirement to treat that within 24 hours. And then that 30-day supply of medications at the time of release. Those are the two things that are required for medications, and that SUD kind of covers that SUD component. We're going to talk about that a little more, and then that 30 days in hand upon release. Some of the common things that we're seeing on that 30 days in hand upon release is that the default, the rule is 30 days in hand. But I do want to call out the last bullet point here. We've talked about the other things here, so that the medications must be dispensed in individual specific packaging, must be billed in real time like any other medication. And then, if there's any refills on those medications, those should also be transferred to a pharmacy of the client's choice after release, right? As clinically appropriate. I do want to call out the 30-day supply of all prescribed medications because this gets asked a lot. Well, what does that mean for, some SUD medications? Or what if it's not clinically appropriate? There are exceptions built into this. I would encourage you to look at the P&O guide because it does call out timeframes of when those medications need to be given and what those exceptions are, right? Some good exceptions to that would be, you started the client on a 14-day regimen of an antibiotic. Well, you're not going to give them 30 days in hand, right? It's only a 14-day regimen. There are some medications, in the Apple Health preferred drug list that require longer than 30 days be prescribed at once. And so I think that brings up another point that anybody who's supplying medications and filling these needs to align with the Apple Health PDL, so those rules do apply. Um, and so there are also, the SUD medications gets brought up a lot, I think, on the 30-day supply. So, if a 30-day supply is not warranted, there are some instances where, it's not warranted to give somebody a 30-day supply. It's a ramp up, right? You start with 7, and then they get 14, and then they get, 30 days worth. And so those rules still apply here. Clinical appropriateness still applies here as well. It's not always clinically appropriate to start somebody on a brand new medication and then send them out the door with no follow-up, right? That's where the case management comes in. If it requires a follow-up by a personal care provider to look for efficacy, is it the right medication? Are there side effects going on here? Does this medication need to be changed? And that's completely appropriate. If you're going to start that medication and make that connection to the PCP and ensure that they have that appointment to go to continue that, that is appropriate. What I would caution against is policies that say our clinical appropriateness is to only give 7 days worth. Then it becomes not patient-centered, it becomes facility policy-centered, right? So clinical appropriateness should be centered on the patient and what's right for that individual. So. Next
And
slide.
Andrew, I had a question because with some like ADHD medicines or quite a few medicines that are really controlled, if in a short-term facility like we have, where a kid could be out in less than 30 days, if a doctor at 7 days prescribes a medicine and they won't fill it before that, 2 or 3 days before that 30 days is up. So you can't actually provide that to them if they get out. So is that like just to make sure that they have a prescription renewal and you've set up the appointments appropriately for them to check in with their doctor afterwards? Would that be covered under that because you can't give them a 30-day supply at release?
Yeah, I would say, here's what I would say to that is there is a refill too soon edit that the pharmacies can use to fill medications in advance if they need to, right? And there's a time frame. Please don't, I'm not the expert here, so I believe it's, you have to use 3 weeks of a month's worth of medication before you can refill it for the next 30 days, right? There is an override edit, but what I will tell you is that all existing safety protocols still exist today, right? So clinical appropriateness would come into play here, and that is it clinically appropriate to fill that medication? I certainly understand that coming from the ER. I would say if they only have 3 days less of a medication like that, and they need to fill it so they have their next month, then you're probably going to be able to fill it anyway, right? It's going to be within the time frame. The other question that we get a lot is, well, what if we have somebody that rebooks in 3 days? We just filled, a controlled substance. Do we have to give them 30 days worth? All those safety protocols still exist, right? So it's really kind of needs to be evaluated by the provider and working with the pharmacy to say, is this appropriate? Or should we go another route? And coming from the ER setting, I dealt with that a lot. And kind of having to judge on a case by case basis, does this make sense? Is this safe? Or can I even do this? Am I even allowed to do this? Right. So hopefully that helps answer that question. But definitely, if the provider feels like it's not appropriate, I think making sure they have that connection and can get their medication filled. I would just be asking, is it clinical? Is it patient-centered, or is it a clinic? Is it a facility policy issue? Does that help?
Yes, it does.
Thank you. Okay, next one. I know we got quite a few slides here, so I'm gonna try to get through these. So I've talked about this. SUD medications and treatment for withdrawal is a requirement within 24 hours, right? We're trying to get people started on medications and trying to get them treated so that you're not having to take them to the emergency room for withdrawal issues. I do want to call out here that we do call out MOUD and MAUD here. Those are the two big ones you're going to see, right? That you're going to see withdrawals probably first, but this really is coverage for all SUD medications. and treatment for SUD, right? So there is some details in the policy and operation guide on this, really calling out that, that evaluation and initiation of new medications for treatment of SUD within 24 hours of confirmation of enrollment in Apple Health. They have to be Medicaid eligible, but we're really trying to get people started on medications as quickly as possible to get them started, keep them from going into withdrawal, and to keep them out of the ER setting, which is, we all know, is labor intensive for everybody involved anyway. So it's what's best for the patient, and it keeps you from having to take them to the ER. Really calling out here, I want to talk about methadone for a second, right? There are some rules in place, but you need to be able to ensure that they have access to SUD treatments as medically necessary. That could mean having a relationship with a community-based OTP program, getting an OTP accreditation yourself, or being registered by the DEA as a hospital clinic. You need to be able to, if the individual is on methadone and they come in and are booked into your facility, you need to be able to continue to prescribe that methadone for that individual to make sure that they can stay on the treatment that they're supposed to be on. So, we're aware that not everybody has an OTP program in their area. That can be a challenge for some of the really rural areas of the state, but there are rules in effect that allow providers to prescribe these medications, and these are some of the ways you can go about that. I know WASPEC has some more information about being registered by a DEA's clinic, and I would encourage jails to reach out to WASPEC. And I know Dr. Stern has given a lot of information on this and has said that it's actually easier than it appears. So I can't speak to that process individual, but I know that he has spoken about that in some presentations I've been in with him. So, and then there is some, rules for that 72 hours, that 3 days worth. Just making and calling that out, that you need to be able to continue that medication if it's prescribed to some. Next slide. And so I'm gonna touch briefly on the Consolidated Appropriations Act. This is really, anybody who's participating in the waiver is also required to provide services to these individuals. This is high level here. And so I'm just calling out that the Consolidated Appropriations Act of 2023, you'll hear this referred to as the CAA. This is different than the waiver. This is something that this is an entitlement. This is federal law now. And so if you're participating in the waiver, there are some extra things for these individuals that the facility must provide. What is to juveniles? And so really want to call out here that the way juvenile is defined here is those 20 and under, or those 18 and older, 18 to 26, who have aged out of the foster care system, right? So we've seen a lot from the adult jails. They're like, well, we don't house juveniles. This was tough for me when I first read it. I had to read it a few times because coming from as an adult correctional officer long time ago, I would have never considered somebody who was 20 years old to be a juvenile, right? They were an adult in my facility. So I'm really calling out that this does affect adult facilities. And so what does the Consolidated Appropriations Act of 2023 provide for these individuals? So there's two sections here. The state has opted, there's section 5121, which was mandatory, and section 5122, which was optional for states, and the state of Washington has chosen to opt into this. So section 5121 provides certain services for those individuals who are post-adjudication, right? Clinical assessment and evaluation, and reentry targeted case management. So the reentry targeted case management is subsumed into the waiver. It already covers, because the CAA says that we're supposed to, provide 30 days worth. The waiver covers 90 days pre-release, so that's covered already. The clinical assessment and evaluation, there are some more pieces. There's part of some optional services in there you can opt into for clinical assessment and evaluation. And if you opt into those, this is going to be covered in that. But if you don't opt into those services and you're just going to do the 3 mandatory required services under the waiver, this is some extra clinical assessment and evaluation that can be billed. And then there's the pre-adjudication, those who have not been sentenced, section 5122, which is full scope benefits as appropriate to provide in a correctional setting. So there's more information to come on that. Very high level. Make sure we're covering that this is in addition to the waiver, and this is tacked onto the waiver in the CBA. It's acknowledged in the readiness assessment that this is federal law. So if you're participating in the waiver, you must provide these services to these individuals. So next slide. And Brandy, I see your question in there. Let me go over this one last slide and then kind of go back. I know we have a couple more slides here. The following are optional services, right? That the facility can opt into. Clinical assessment evaluation. It's a pretty big benefit. A vast majority of the code list that you'll see online is the clinical and assessment evaluation piece. So if it falls under that assessment evaluation, we asked, is this appropriate? Does this fall under clinical assessment evaluation? And would we exclude somebody simply because they're incarcerated? So it is a pretty extensive code list that would cover this. The pharmacy, in addition to that 30 days in hand upon release, you can cover medications in the 90-day pre-release period as well. Laboratory services, I think that kind of speaks for itself, and radiology services, that as well, x-rays, things of that nature. Medical equipment and supplies at release. Want to define this a little bit because in the pharmacy piece and the 30 days in hand upon release, that also covers those medical supplies that are on the Apple Health preferred drug list that would be filled and dispensed by a pharmacist. I always use the example of, insulin Lansensis syringes, right? You go to the pharmacy, you give them the prescription, they pull it off the shelf, they fill it as a prescription. Those are covered in the 30-day in hand upon release and the medications during the pre-release period. The medical equipment and supplies at release, what we're really talking about here, this is an optional benefit that you can opt into to where you can hand them those DME type supplies at release and set up. It's pretty extensive too. We run into some correctional facilities that really struggle with, they can't fill a medical supply because their coverage isn't active. And so we really took a look at it from that angle and said, they may need to set this up at home for them. And we wanted to make sure that you could do that if you want to opt into that. And then the services from providers with lived experience. This is a defined benefit. So this encompasses 3 different benefits that we have. So there's the doula benefit. We wrap that in there. They're going to serve an important role and really fill that gap. There's also the certified peer specialist, which is an existing benefit that exists within Apple Health and Medicaid with the state of Washington now, and the brand new community health worker benefit that was stood up here on July 1st. So those 3 benefits are the benefits that are covered in the services for providers with lived experience. Before I pass back off to you, Monica, I do want to go back to Brandy's question, and she asked, how does the release medication policy apply to long-acting injectable medications? Well, you wouldn't give them 30-day supply of that, right? It could mean that you give them their dose as they leave, right? And we did that in the ER a lot, if it wasn't appropriate to give to them, but we could give them an injection or give them their dose as they go out the door, then we would give them their dose as they go out the door and make sure they have that connection and know what the next step is. Does that help?
Well, my question is more like if they're receiving Sublocade, for example, in our facility, either because they were receiving it in the community before they were booked or because we inducted them onto it while they were in our care, and they release and it's 2 weeks until their next injection is due.
It's not due.
What is our requirement there?
I would say what I would do is I would that's where the case manager would come in to make sure they're connected with where do they go next for their next dose, right? You're not going to hand somebody the supplies to give them their own injection or, right. Right. So that would be making sure they're connected with that next step and, where do I go to get my next dose and on what day do I go, right? So you're definitely not going to hand somebody a medication that needs to be prescribed and administered by a medical professional. So
because the waiver is so tightly focused on SUD medications, MOUD medications, could that be added to the policy and operations guide as a specific explanation? Because that's where our practice is going. I imagine that's true all over the state, and it seems like it would help to have that spelled out.
I can take a look at that in there. I think that would fall under the clinical appropriateness, Brandy, because it wouldn't be clinically appropriate to either give somebody their dose 2 weeks early, and it wouldn't be clinically appropriate to hand them the supplies to give it to them themselves. So that's my thought on that, but I will take that feedback back.
Okay, thanks.
Yeah. All right, Monica, I hope I left you enough time. I talk a lot, so.
Yeah, no, you did great, Arthur. Thank you. So, one of the things that I would like to pick up on is the IT and infrastructure budget. And so, HCA will provide capacity building funding to facilities to support the planning for and implementing the Reentry Initiative. And with that, we have allowable expenses, which include things like hiring of staff and training, development of protocols and procedures, additional activities to promote collaboration, planning, other activities to support an environment appropriate for provision of reentry services. Some of the allowable expenses under the IT budget are things like electronic interface to support the enrollment and suspension. Also, any enhancements to any existing IT systems that are going to be in support of the reentry services and navigation services. Adoption of a certified electronic health record, also known as an EHR, and technology. And then this could also cover any of the installations of the audio or visual equipment and other technology. I do want to share. Can you go to the next slide? And I want to make sure. Yes. So I also want to share that maximum funding for reentry planning and implementation will vary on facility size. So based off of their average daily population. So the maximum IT infrastructure will be 1 million for each participating facility. And then as you see on this table, you have the intent to participate where facilities based off of their tier size can get up, 10% of the total capacity building funds upon just submitting, hey, we want to be a part of the reentry initiative, right? And then for milestone 2, which is what cohort 3 facilities are going to be preparing for. Upon that approval, facilities can get up to 40% of their total capacity building funding. And you have the 500,000 upon approval for the IT funding as well. And the due date for that. And then the milestone 3, the readiness assessment, you will get up to another 40% of the total capacity building funding, again, based off of your tier size. And then the other 500,000 of the IT funding as well. And so I do want to pause to see if there are any questions before turning it back over to Michaela. Brandy?
Thank you. I did have a question about how the funding works under this contract. So with our other state contracts, we bill monthly based on our actual expenditures. What is the billing process for us to receive funds under this new contract?
Are you referring to reimbursement for services that are offered, or are you
No.
talking about the funds that I just went over?
Yes, the capacity building funds.
Okay, so the capacity building funds are dispersed to the facilities once you complete each milestone.
You just send us a big bulk amount of money.
Yes, ma'am.
And then what is the process for us to report back to you how we use the funds? Or if we don't use them all, what's the process to send you back what we didn't use, for example?
So in terms of like not using the funds, there are allowable and unallowable expenses that facilities can utilize the funds for. Details of that can be found on the website as well. The funds we do not ask for a report to answer the question of like, hey, did you please show us like an itemized list of what you use the funds for. That is part of the reason why we do go through the assessments the way that we do, really getting a detailed overview about the facility's intentions on those funds and how they're going to be used. And then as we check in to do the progress reports and the final progress reports, we should be able to see and report back that you all have implemented as planned. Did that answer your question, Brandy?
So you want to see that we've done what we said we were going to do, but you don't want to see specifically how we spent the funds. Is that what you're saying?
Right. That's already being documented with the budget that you're submitting.
Right. But a budget is a plan. I know that, actual expenditures often vary from initial plans one way or another. Um, so you're saying this will not be reported?
I am saying that we will do follow-ups with facilities to see how things are going, and that our physical team is the one who oversees budget disbursement, and I can always have them reach out to you. If you put your contact information, in the chat, I can make sure to get that over to them.
Okay, thanks so much.
Yeah, of course. All right, Michaela, back to you. Thank you.
Yeah, thanks, Monica. This is really just at this point an open forum for any last questions. I know we only have a few minutes. And Takina, can you go to the next slide? So this slide deck will be posted or already is posted on our website, and has a lot of really useful resources. You can also always email the Reentry Initiative inbox with your questions. Um, Actually, Brandy, I might ask you to email the inbox directly with that specific question. That'd be very helpful. Is that possible?
Sure, yeah, I'd be happy to do that.
Okay, thank you.
Mhm.
The current version of the capacity building application that we have listed on our website is not the most up-to-date version. We are in the process of finalizing the most up-to-date version, so I would just encourage you to review this slide deck, and you can take a look at the CBA that we have currently posted, but I would not start working on that necessarily. We anticipate having the updated CBA published next month, and we will send out a notification when that is posted. So, does anyone have any last questions before we wrap up here? All right, well, I'd just like to give a big shout out to our presenters today, Monica and Arthur, for really helping us move through this. And thank you all so much for coming. Um, Again, please send any questions you have to the reentry inbox, and we'll talk soon.
Thanks all.